Welcome, everybody, and thank you very much to this presentation by Dr. Mandondo, an amazing district ops and gynae specialist from UCT, and currently working in the Amathole district here in the Eastern Cape and doing amazing work in terms of bringing down our perinatal and maternal mortality. And tonight she's going to speak to us specifically around early severe sepsis and around some cases that they've seen here in the Amathole district in the Eastern Cape. And I'm going to hand straight over to Dr. Mandondo. Thank you.
All right. Good evening, ladies and gentlemen. Thank you for joining us for this session. I'm going to try and be rushed, but I'm talking about pregnancy-related sepsis. I think the reason I'm presenting this is because I'm going to present two short cases, but I think that you are the make or break. It's either patients are going to die or patients will live. And the first person, the first hour, the first contact is what is going to determine if these patients live or die. So we're going to take case one, who was a 33-year-old. She was graph 3 para 2, 21 weeks by date. She was unbooked. She requested a TOP, and she was told that she was late. She was already 21 weeks, and she was advised to go and start antenatal care. She was also tested for HIV, and the HIV test was positive. Then she presented on the 27th in January, this year, right, with history of dizziness, diarrhea, nausea, vomiting, hot and cold flashes after ingesting 17 doses of misoprostol. She says she got this. This was a self-induced TOP. She says she got this at some clinics in Oxford Street, which we know there's no women's clinic. This is a backstreet abortion. At presentation, she had a pulse of 114.63, a pulse of 128, BP is 114.63, respiratory rates were 12, the temperature was 39. Remember, misoprostol, if you take high doses, it will cause rigors in the high temperature. So this was due to this misoprostol. If you're looking at the shock index, it was 1.2 and on admission. However, the person who saw her assessed her as an inevitable abortion because she could see that the products were still inside, the os was open and she could feel some leaks, gave antibiotics, but this patient did not abort. The patient went and stayed in the ward for 2 days, and then on the third day, she just crashed at 2 a.m. She was resuscitated, transferred to ICU, intubated, and died. And then in ICU, she died 5 minutes later. So this is a patient that is badly managed, and it's a maternal death. Okay, let's look at the age. Let's look at the second case, because that's why we have these talks. Here, we've got a second case, different scenario, different place. 29-year-old graph 2 para 2. We're going to spend a lot of time on this case now. And I'm going to, through presenting this case, show you how you should manage these patients and how you should clock patients which you actually see. So this patient was admitted on the 4th of June, which was at 5 a.m. Very dangerous time to present. She really resided in Naidujwa, and she had a septic self-induced miscarriage. She had previously been seen, which highlights some of the gaps in our care, at the health center on the 3rd, which was the day before. But when she presented there, she had presented with a sore throat, vomiting, and epigastric pain. Nothing pregnancy related. She had a temperature of 36, pulse of 57, the BPs were 78 over 54, and the shock index was actually more than 1. But the problem here, there's a mistake here. Then the problem here was that no one did a pregnancy test and no one did a urine dipsticks. And remember, colleagues, all patients of childbearing age, a pregnancy test is a vital now. So you have to have a pregnancy test before you move on and make other diagnoses. So the doctor, the person who saw her just says, this patient has got tonsillitis with this sore throat, gave her 2 grams of ceftriaxone. And then the patient the next day then presented at FRE. The next morning, again with this cough and the sore throat, general boils weakness and the shortness of breath. She now did mention that she had been PV bleeding for a week, but at this time there were no clots. She denied pregnancy initially. She did not mention anything about passing any fetus or seeking abortion. Then the pregnancy test was done. And then when it was positive and she was confronted, she volunteered that she attempted unsafe abortion. She took misoprostol. She had taken the misoprostol on the 10 days earlier. And she did mention that she had had this sore throat, which was worrying her. So when you assess a patient, you look at the big 5 organ systems. The GCS was 14, you look at the CVS, the pulse was high, and then the BPs were 75 over 40. So every time you see this, you must actually take what? You must take the pulse divided by the blood pressure, systolic blood pressure, which is giving you almost 1.8. So this means this patient is extremely ill. Respiratory rate of 41, the sets were as low as 67. She was jaundiced, but the abdomen was soft. There was no urine output. She was cold in the peripheries, poor capillary fill, increased urea and creatinine. So after you did the big 5 systems, you look at the forgotten 4. They did an HB, which was 13, but the platelets were 26. And the white cell count was 18. The temperature, she was hypothermic, so which is also another near-miss sign when patients are hypothermic, but the glucose was 7.8. The DVT was nothing was noted, but she was suspected to be coagulopathic because she was oozing from the drip sides. Looking at the genital system, they noticed that the uterus was bulky, abdomen was tender, the cervix was open with a foul-smelling discharge. So you can see this patient was more like very systematic clacking and very systematic management. So the intern that saw her actually was quick to say, help. She actually even called the consultant, not just the medical officer. She recognized that this patient was actually in severe sepsis or severe shock. That's what she documented. She started the fluid resuscitation. So we're going to what is the right way to manage these patients. So you start fluid resuscitation. You start it at 30 mils per kg of warm fluids because this patient was hypothermic. So you need to put the fluids in the bucket, some hot water and start at 30 mils per kg. So which is almost 3 liters for 100 kg. You need to obtain the relevant cultures, which was blood and the urine. And then you start the IV antibiotics, which will be ceftriaxone or Flagyl in the district hospital setup. And then in a higher level setup, we can start with something bigger, a higher level antibiotics. The diagnosis of septic miscarriage was done and the secondary survey was done. So the management is actually source identification and site control. And the patient was booked from casualty without going via any ward, straight, and a total abdominal hysterectomy was booked state because evacuation of the products was not an option for this patient. She was way too septic. Now, the next thing that you do, this patient, after getting fluid resuscitation, they realized that they did what you call a passive straight leg raise, and this passive straight leg raise was negative. Therefore, this patient was booked for ICU. So those of you who do not know what is a passive straight leg raise, it's something which is worth learning about doing in our setting because we don't have central lines, we don't have CVPs. So how do you do a passive straight leg raise? Why do you do it in the first place? So you have a patient that you're resuscitating, you're giving fluids up to 30 mils a kg, but the blood pressures remain low and the pulse remains very high. So in order to test whether you want to give more fluids or you need to start the inotropes, you need to put the patient in a semi-phallus position, right? Then if this is not possible, the patient may lie supine. Then before you do it, you record the pulse and the blood pressure. You inform the patient what you're going to do in terms of the procedure. And then what you will do is then you're going to lower the end of the bed, right? So once you lower the edge of the bed, you're going to raise one leg, right? You need to put one leg, raise it up to 45 degrees. And then you actually wait for 2 minutes. After that 2 minutes, you check what has happened to your pulse and the blood pressure. So what you expect to do, then the blood pressure should actually improve and the pulse will come down. When this happens, it means that this patient is actually behind in terms of fluids. So there's room. So when a patient is in shock, part of resuscitation is to give IV fluids. In some scenarios, it's difficult to decide how much to give. And if you give too many, it can be harmful and can cause some of the patients to go into pulmonary edema. So when advanced methods such as arterial pressures, CVPs are not available, the passive straight leg raise is a very useful test. So now once we lift the leg, right, if you lift the leg, you allow the fluid that is pulled in the venous blood right off the leg to go towards the heart. This was then is like simulating a fluid bolus. This creates an opportunity for you to assess the response to a fluid bolus. The advantage is that it is reversible. So if you then raise the legs and there's a 10% improvement in what? If the blood pressure improves by 10% or the pulse decreases by 10%, this means that the test is positive, and therefore you can actually add more fluids. But in some cases, you can give the patient, you do the passive straight leg raise, and when you raise the leg, the patient starts coughing, is almost in pulmonary edema. And if that is the case, then it means the patient cannot tolerate any more fluids. So what you need is to put up an IV line, put up inotropes, of which you can use 5 m's of adrenaline in 200 mils. You start it at 5. when you put the adrenaline, you're not going to put it on a peripheral vessel like a terminal vessel. You're going to use a big a big gel core, like a green or a gray, and you're going to put at least on a cubital vessels to ensure that the patient can then, you don't damage those vessels which are terminal. So if this, I'm continuing with this presentation. So this all was done by this intent because we learn, we drill, and we present so that you can change your actions. When after taking the blood, the patient then had the TAH, and then this patient was then admitted to ICU because she had multiple organ failure. She needed dialysis with creatinines of 639. She needed inotropes, which were commenced as soon as she arrived in theater because the BPs had remained low despite. And then after that, she then went to the ward. This patient, remember, her primary complaint had been a sore throat. And therefore, it was then suspected that the ENTs were called and it was suspected that she's got septic emboli. And with this, or a transient stroke, because she had difficulty swallowing. But then what then led to the diagnosis being made of septic emboli was when they noticed the dry gangrene on the toes of the patient. So now this diagnosis of multiple septic emboli was confirmed by seeing the gangrene on the toes. If you're looking at the blood gases, you can see that the HB was 11, the platelets were low, potassium, urea, creatinine 602, INR 1.3, and the D-dimers of 70. Blood gases showed the metabolic acidosis, and an ECG was done. And then this patient was then sent back to high care, and then she stayed in ICU for a while until she was dialyzed. She improved her creatinine to 120, but the urine volume remained low. And the question was, what are you going to do about the septic emboli? So it was decided that this patient couldn't, she needed an amputation of the legs, of the toes, but considering the amount of sepsis that she had been through, surgeons were reluctant to amputate, and therefore this patient, they opted to keep it because it was a dry gangrene. They kept the toes, and they say they will wait for these toes to auto-amputate. A chest X-ray was done, and the CTPA was done, which ruled out a pulmonary embolus. She was sent to the social worker for counseling and discharged 2 weeks later. Why am I talking about this case, colleagues? If we're going to look at, there was a study that happened before the termination of pregnancy became legal. This was the bread and butter obstetrics of our country. Patients with self-induced abortions, whether they're using MAS or whatever. But then Oris did a study. So what had happened is that among the tertiary and the regional hospitals in the country, they had 44,000 women that were admitted. 425 women died of these septic abortions. 15% had this severe morbidity, whether they had hysterectomies or they had ICU stays. Others had moderate morbidity like renal failure or other things. And this cost the department 9.7 million. And then this was actually presented in Parliament. And when it was presented, it was looking at the cost of the unsafe abortion in the public hospitals. And then when this was presented in Parliament, they decided that we're going to have the Choice of Termination of Pregnancy Act, then abortion became legal. And then after the abortion became legal, a few years later, they looked at the same hospitals to look at the number of hospitals. The number of the abortion-related mortality had dropped from between 1998 and by 91%. So you can see from the 1994. So you can actually see that this, if the people have access to CTOP, then the persons will not die and they will have a legal CTOP. But now the CTOP is legal, but people are still dying, and we're still having these patients that are presenting late or the ones who are presenting with sepsis from backstreet abortions. All of us know that it's a very common thing to actually see these abortion posters all over. So if you're looking, these are the posters I'm talking about. We all see these. We see them everywhere in our hospitals, on the taxi ranks, in the malls. And the thing is, this unsafe abortion is continuing, and people don't know the difference. When it says Dr. Jim, they don't know the difference between places of legal termination and illegal terminations. And when patients come and visit our hospitals, there are many things that are actually denying them access to this abortion. So if you look in the country, then the abortion, right, it's actually ranking. If you look in the whole of South Africa, really the issue of miscarriage, in the whole of South Africa, it's at 7.18 per 100,000. And you look at Eastern Cape, we're at 3.68. And really in 2020, this is really starting to rise. So the reason that the problem in the country is that there is a number of these that are happening. So if you really need to assess, you are asked to assess any patient, you can see that patient one, the abortion was an incomplete. She had aborted the baby and the fetus, but she had retained products. So this is an incomplete. But if we look at case one was an inevitable. The baby was still in utero. Someone could feel the legs. But why is it that the person who's admitting then needs to make a decision? Do I give this patient antibiotics? She already got fever, Ricos, looks shocked. But then the question is, when you admit this patient, you should watch this patient. You need to give her either more misoprostol or oxytocin to make sure she expels that fetus. But what happened is that the patient was admitted 27, 28, 29, and died on the 30th, 2 days, where that fetus, we don't know which day that she took those 17 misoprostol tablets. But the thing is, if you do not expedite the delivery, then you're going to have problems where you're going to have an inevitable miscarriage, then that becomes septic. So in your hospitals, you must remember that you can do evacs of patients where this is an MVA at the CHC level 1 hospitals, when all the vitals are normal. And when I mean normal, you want to make sure that you have a pulse of 90, respirations of less than 30, normal temperatures, and a uterus of less than 12 weeks, and no products. So this type of patients, yes, are within the level of the district hospitals. And this is an uncomplicated miscarriage that you need to manage, either to give more miles or to abort, or to make sure that you evacuate if the products, if it is incomplete. But if you then have a complicated miscarriage, any of the things that we see in the patients that I've discussed, fast breathing, increased heart rate, altered mental state, low BP, septic shock, tender abdomen, open cervix, this is suggesting that there is a miscarriage. So we used to have this terminology called severe sepsis, where we're going to have organ dysfunction. So the reason we approach the patients by saying there's a big 5 and we do cardiovascular. So what are the things that worry you? Is when your BPs, in obstetrics, we worry about BPs less than 90, respiration more than 26. You know that in normal respiration in pregnancy is 25. More than 25 is worrying. When you've got oliguria, 30 mils of urine, right, despite having given fluids, altered mental status, and then there's also decreased capillary refill. So, and then we used to call this septic shock, right, which is hypotension after the fluid resuscitation, which we said, originally we used to talk about fluid resuscitation as 20 mils per kg, but now we're talking about 30 mils per kg. So those are the key changes, right? So I really now, what has happened is that now there has been this international sepsis, the consensus statement for sepsis. And we all know that we all do triage in our casualties. But I think the most important thing with this is that it's very important that there is a sepsis consensus. And now, instead of calling it severe sepsis, septic shock, they have changed this the terminology to what is called the sequential organ failure assessment. So when you talk about sequential organ failure assessment, it must be a score of 2 or more points. And what is actually important is that if you have this sequential organ failure assessment, I'm going to tell you what are the parameters of this. But basically, the higher, if the points are more than 2, then it means that there's a higher risk of mortality. And if you think that now you can't even manage the patient with only fluids, it also means that the patient now needs vasopressors, have to maintain their mean arterial pressure of 65. And then we also use this serum lactates to actually manage the patients, right? So how do we then do this score? So initially, you guys know all about the SERS, because the SERS patients were really the patients with high temperatures, high pulse, high respirations. But now when we talk about the Q-SOFA, we talk about the what? The Q-SOFA, which is now 2 features. So remember, when you do the SOFA score, it's either using biochemistry or using clinical science. So when we're looking at clinical science, 2 things really need to be important. If you have a respiration, you eyeball anytime you are being called to see a patient in casualty. When their respiration is more than 25 and their blood pressure is less than 100 and they have altered mentation, then that means their Q-SOFA score is more than 3. So these are patients that need to be prioritized by the patients, by the nursing staff. And you must also now, when you clock these patients, you see these patients, you must know that these patients are patients that you really need to watch out for. So then this Q-SOFA score, then you actually use biochemical markers. So what is important, we actually do blood gases, as you've said, and you can see that the KPAs, you can see that as from 400, it's fine, and 100 is a score of 4. So once you've done the blood gases and you look at the millimeters of mercury of the PaO2 or FiO2, then you actually assess. So in our patients, what I've put in red, you can see that in the patient we're discussing, she had a score of between 200 and 300. Then platelets are very important, right? So your platelets, the lower the platelets. So if you see platelets of less than 20, it's worrying, the score is 4. When they are between 20 and 50, the score is 3. 50 to 100, the score is 2. 100 to 150, the score is 1. And more than 150 is normal. Then you actually do the bilirubins, right? So you can see the bilirubins, it must be between 20 and 32. And then then when it goes higher than 200, you can see the patient is ill. So our patient was between 20 and 32. Then if you go on the CVS, you look at the mean arterial pressures, it's less than 70. So this patient, before they get dopamine, right? So she scored a 1. So then you then look at the CNS, and we said with the CNS, you're really concerned about whether the patient is having a good GCS, or you can see our patient had a score, the GCS was between 13 and 14. And then you look at your creatinines. So you can see creatinines, when your creatinine is between 100 and 170, and then if it goes for more than 400, then it's high. And then the urine output. So we can see that our urine output was less than 30 mils. You can see if there's less urine output, right, then there's that. So you can see this patient that we managed, that we're able to discharge home, was managed extremely well. And what was the difference? It was the first doctor that saw, who really said, look, this SOFA score is high, did all the bloods, blood gases, did liver functions, did UNEs, did FBCs, and really did all the cultures. And this patient was able to escalate to send this patient to the next level and to activate a response team that responded. And by grace, there was an ICU bed, there was a theater, and the theater was available within that 1 hour. Otherwise, when you're doing this resuscitation, you need to really start the antibiotics. You don't just write it up and wait for the nurse. You call for the antibiotics. You give the antibiotics in front of your eyes, right? And therefore, if you were going to do an evac, you need to give 2 hours. If you have the time, the patient is stable. Before then, you go and evac a patient that you think needs evac after giving the IV antibiotics. The antibiotics of choice will be cephalosporin, 3rd generation, and then it could be gentamicin, 5 milligrams per kg. And then you can give metronidazole. So this cephalosporin gender and it's very important that you use the gender. You know that we don't use gentamicin in obstetrics under G, but in this early pregnancy sepsis, gentamicin is important. Then if you're doing the resuscitation, you really need to make sure that the systolic blood pressure does reach the 100, CVPs more than 8, the sets must go more than 90, respiration must drop, and then you need to aim for the HB. So you need to make sure you give blood so that you can optimize your patients. Now, why did the intern see this patient and say, this patient needs a hysterectomy, and call a consultant, call the senior medical officer who was on call? It's because you could see that there were 2 organ systems that were affected. These patients remained hypotensive with a high shock index. And then despite that, also the renal system was affected, and you can see that the mental status. So definitely this patient needed a hysterectomy because there were 2 organ systems that were affected, and they didn't improve despite any resuscitation. So in obstetrics, right, within the first hour, you need to do this septic 6 bundle. What is that? Oxygen. Really make sure that the sets improve. Blood cultures. Don't just take urine. You need to take urine culture, you need to take the products, and you need to take blood to consider the source of the infection. Then we said in a tertiary setup, you could use a broad spectrum like meropenem, but the ones that I've described, the KEF, the Genta, and the Flagyl is good for the first hour in a district setting. 30 mils per kg, and you do the passive straight leg raise test. Then you actually record now, right, every 15 minutes, BP pulse, urine output, and oxygen, and you actually judge your clinical response. Do an ECG, and then you can do the CVP. And then the good indicator of tissue perfusion will actually, when there's an improvement in the CVPs, if you've done a CVPs, and then you give 500 bolus if it's less than 8. But if you don't have a CVP, we say, and then you maintain the fluids at about 150 mils per hour. But if not, you will just do the passive straight leg raise and keep on giving boluses in addition to giving this fluid at 150 mils per hour. So the 1 hour bundle, the culture, the lactate, broad spectrum antibiotic crystalloids, and vasopressors, then you can go on to investigate and do the CT scans, and then you can do the soft control. So the source will actually have to decide where is the fetus. So you can see that Dr. One realized there was still a fetus in utero, could feel that the membranes had ruptured, could feel that they can see products, but didn't expedite the source to really make sure that this fetus is evacuated. So 2 days later, patient is still in the ward, not aborting, and then she crashes. So that source control is very important. Get rid of the products. So if you can't do source control, you can't do an evacuation, you don't do then you have to do a hysterectomy. We don't do any monitoring of the fetus if it's less than 26 weeks. And the worst part is to do all this and give no definitive prophylaxis. So if you see a patient that you're suspecting sepsis, then you need to consider that you need to put something for DVT prophylaxis, because you can do your hysterectomy, then the patients can die of a pulmonary embolus because they are at high risk for sepsis. And then the second thing is do a full examination, right? There are many common causes of sepsis that you can see in a patient. So because you're seeing these products, don't just assume this is all there is. You need to, sometimes the patients are even post-delivered, but we're talking about early pregnancy sepsis. So you need to make sure that you check sinusitis, you check the CVS exam, you do the urine, there could be cystitis, GIT, the DIC, you can have some septic miscarriage, and then you can look at breasts if the patients are post-delivered, and they can also have this aspiration pneumonia. Then after you have had a patient that is going home that will had a septic miscarriage, really you need to discuss the resumption of intercourse. You need to discuss contraception. Will they use contraception now? Which contraceptive methods will they use? Remember, at least for 6 weeks, you can't use anything with estrogen. Then in the grieving process, we also remember the patients who had miscarriages can resusc sensitized. So if these patients are Rh negative, they also need to be given anti-T. When to conceive, allow time, maybe 3 months before they can conceive. And then the cause of miscarriage, we can see most of the time, these could be self-induced, right? But then it's actually very important that you also talk to the HIV. I just want to talk briefly now. Sorry, I'm just taking the time. Okay, quickly. This abortion act, I just want to make sure that we are all clear, because now what do you do to the patient? Now this patient took abortion pills, right? And they got it from the street, and it is illegal to buy abortion pills from the street. So what does the act say? It says any patient who's not a medical practitioner who gives anyone who hasn't been trained, who's not a medical practitioner, who gives someone misoprostol, or then can be liable for a fine for up to 10 years. But anyone who is like even a pregnancy, even if you're a clinician, you obstruct access to a facility for TOP. So which means that if you say a patient, like with this patient, the first patient who was a maternal, she did go and ask for a TOP, then you must document that you've seen this patient, you've referred her to the antenatal care clinic. She is 19 weeks. That's what you thought, but you scan her, you think she's 21 weeks, you write that you are over, and you must write it, put it in writing, put clear notes, because you mustn't be seen that you're obstructing access. But we have a challenge in terms of facilities that are able to do the TOP. But what about the patient? So now if this was your patient who had gone and taken this 16 misoprostol tablets from the street, what is the problem? You cannot report this patient. If you report this patient to the police, then the patient, will also be guilty of an offense or a fine, and they can also be imprisoned for up to 10 years. So this is the problem why it's very difficult for patients to volunteer that they took the misoprostol. And even if they did, the person who gave them the misoprostol is liable for an offense, is guilty, but the patient as well is also liable for an offense, is also guilty. Why is this TOP not working? Why are TOPs available? I think the problem is that really the nurses and community members really, they don't come support the TOP. They are supported for rape and incest, but really there is very low support. If they were asked, there was one study, if they were asked for financial reason or mental reasons, you know, those reasons really are not acceptable to most people. What is the impact on the staff? Really, somebody has studied the staff with the depression, anxiety, religious conflicts, right, in patients who are participating. The staff are actually victimized by other facilities. They are not even eligible for promotion. Like a person can work there, but if they apply for a job, they were running a unit, you're applying for a management job, they don't get these management jobs. Really, there are things like various clarification workshops, really that, you know, some of the staff victimize the TOP providers. So I think the misoprostol, the problem with misoprostol, how can you prove it? Because a patient can deny what they said because it's got a very short half-life. And if the elimination is within 20 to 40 minutes, so, and we don't have any assays to prove that a person took the misoprostol in our country, it's very high cost, and it can be assayed, but we can't assay it because you can see the patient can take miso, and then like the other patient presented 10 days, and after 10 days, then she presented to the facility with the abortion. So it's very easy to prove this patient, so that patients can be criminalized or arrested for this. Also the advertising, right? So they also say this, the Advertising Act says that advertising is service to the public, and as such it should be informative, factual, honest, decent, and the content must not violate any of the laws of the country. So these posters, if people are seen putting up these posters, they are doing something illegal, and really they need to be dealt with. And if you, I'm almost there. I've looked at articles when they're talking about why people do this, how do people get into this business? And I saw a very interesting article when Ellie says, look, I was pregnant and then I had to start doing this. I went for a TOP, and then she went to somebody, and then this person sold her the misoprostol. But after that, she started thinking, why don't I sell these pills myself, you know? And then they say that they buy these cytotex, 60 cytotex for 350 rand, and they sell 2 pills for about 200, 4 pills for about 200 rand. So you can see 16 pills will be 4, 8, 12, 16, will be 800 rand or more, or 1,000. So really that there's a need for vigilance. There was a time some of the TOP providers, the thieves, these guys would follow them out of the clinics and say, please sell us some pills. So really everyone is starting to make money out of this because it's easy money, because there's no access. So what really needs to be done, really, we need to reduce these deaths. One, the pregnancy testing policy. So for all our new ComServe, our doctors, if you work in casualty, pregnancy, age, childbearing age, do a pregnancy test as a vital, make sure it's there. Number 2, very few of the interns and the ComServes know how to insert an IUCD or an implant, which is a problem because younger people can, if we knew how to insert these devices, there would be some reasonable uptake. 3, access to second trimester CTOP is really an issue, because if you can look at in the whole central region, only one hospital, CMH and Frontier, are doing, then Fresh sometimes have no beds. So this is a problem. 4, when you do an evac on a patient with a miscarriage, maybe the pregnancy was unplanned, we really need to look at post-abortion contraceptive care. Once you're doing that evac, why don't you put an IUCD on that patient? You need to really clarify to the patient that you can put an IUCD. And I had a question today. If you put an IUCD and the patient has a discharge, do you remove the IUCD? No, the protocol is very clear. If the patient has an infection or discharge, they've got an IUCD, you do not remove the IUCD. All you simply do, you treat them like you would have treated any other patient with a PID. Various clarification workshops are really important among the staff so that the staff still feel part of the team. And then political influence, we have seen that there have been multiple maternal deaths. I present one, but probably every quarter there is one maternal death in the province from this self-induced abortion, let alone the TAHs and the hysterectomies and the ICU stays. So we are going back to the remember there was 540 maternal deaths in that other study, and we're heading there if we really don't pay attention to access to TOP and contraception, or we don't pay attention to contraception care. Conscientious objection. All the doctors, when they don't want to work, they come work in the institution and they say, no, I object to doing TOP. You can object to initiating TOPs, right? Giving misoprostol, but you cannot object to evacuating patients, seeing patients, and managing patients who have done a TOP or who have complications of the TOP. Really, it's very important that we need to work on this. So we really think that we need to really audit now. In your hospitals, you can look at other strategies, but we really need to audit these near misses. And really, we also need to look at the patient avoidable factors, but also address barriers, right? Why are we not having? Many people come for the training for these CTOPs, but you come to the facilities, you'll get very, very few. You say there's people who are doing CTOPs, but I can just make an example in our hospitals. Adelaide 3, in a quarter, Bedford 11, Butterworth 258, Cathcart 9, Aidutya 128, Nompumelelo 33, Right Ngamakwe 8, SS Gida 6, Victoria 108, Kocha 12. So these are all people who say that we are doing CTOPs, but look at the numbers. I don't think it just matches by any means the demand. Look at implants. Look at the implants, right? Look at this, Adelaide 7, you can see Butterworth 127, Aidutya 36, Matwellen 131, Victoria 79, Kocha 10, you know, the numbers for the IUCDs and these contraceptives, but if you were to look at the numbers for Depo-Provera, there would be thousands, hundreds, you know, so that's something we need to do. Really, we need to do this research again on miscarriages, and really we need to look at other health promotion strategies. So we need to really improve as a department. We are running a serious risk of morbidity and mortality, and we can see that there's lots of mortality from this, and we really need action, and we can't be too busy. You know, there is too much resistance to doing CTOP. Thank you very much. I want to support that tomorrow we're having another talk, which will be talking about all the issues on CTOP, the ethics, the complications. So if you are keen on that, we will share the link. Thank you very much.
Sure. Thank you very much, Dr. Mandondo. It's lovely to hear it from the horse's mouth, from somebody you can really see who's right there at the coalface and supporting our rural doctors with these complications. And this is the kind of presentation that saves lives. So thank you very much. I would like to open the floor for questions. You can either put your question in the chat, and please do remember to put your details in the chat if you've not yet done so for CPD, and if you're listening on YouTube, to put your details in the YouTube chat. But otherwise, you can also put your hand up, or if any of that is struggling, you can literally just unmute and chat, just to hear if there's any questions or comments, or also experiences from people in that is listening to this meeting. And I'm just checking also on the live chat if there's anything on there. There's a question I see on the live chat about the slideshow. What will happen, Dr. Mandondo, are you happy for the slideshow to be made available?
Yes.
Right.
No
well,
problem.
What we'll do is we'll add that to the Google folder of the rural onboarding, or I'll put a link for it into the YouTube video that we'll be sending around. So this will also be recorded and will be on the Rudasa YouTube channel to be able to share for colleagues and to show to colleagues in your facility. And then we'll make those slides available as well, because there's some very useful tools in those slides that people might want to have access to. I'm just looking.
I can also share a fire drill that, you know,
Yes.
some of these things you need to, instead of the presentation, take a fire drill of someone who has a septic miscarriage who's presenting at a casual, and then you can role play the whole scenario in your hospital. So I would really appreciate it if the people in this talk today, they can, rather than, yes, you can listen to the presentation, but I'll put the fire drill so that you can go and role play the fire drill in your casualties, in your wards, so that people can become more aware about this, and really that we can improve our vigilance in terms of managing these clients.
Thank you very much. If you email that to me, I'm going to send it around when we send around the video recording. There's a question here that between 13 and 20 weeks, the CTOP does allow for an impact on SES, but I was informed by staff Fred does not allow for this option. Just wanted clarification on this. Do you know, Dr. Mandondo?
No, Fred does allow, but the problem with, which is what we're going to be discussing tomorrow, other provinces have come around this by initially everyone who was 13 to 20 weeks had to have, were having their termination of pregnancy as an inpatient. So now you find you start the misoprostol and the patient goes on for 2 or 3 days without aborting. So what has happened in other provinces, they've started allowing them to do it as outpatients, and then they will maybe admit only the 18 to 20 weeks. So now more beds are available, no beds are needed, and more people can have the access. So I think this is the access challenges that we have, and we're gonna work on. That is what Fraser is having a challenge with. It's the beds to admit everyone who's 13 weeks and more.
So that's us, yeah. So that's a major challenge that we need to think about as a province as well, in terms of access also in some of the other districts.
Exactly.
And there's just a comment here on an impressive talk from the heart. And we always love your passion with which you are looking after the women here in the Eastern Cape. And I'm sure there are lots of rural doctors that are doing that across the country. And it's so important to look at how we create access for these women. I'm not seeing any last questions in the chat, and there are no hands up. I just want to see just some grateful appreciation in the chat as well. I'm going to quickly launch that poll. That's just useful for us to get a bit of feedback in terms of how useful you have found this presentation, and also in terms of being able to just check who was here in case we missed you in the chat. So please do fill in the poll for us. It's helpful for us also to plan future topics. So thank you very much. And then, yes, I'm going to then say thank you very much to Dr. Mandondo for this presentation. I'll be on the call for the next 5 minutes or so, just doing all the last administration. So do please do the feedback poll before you go. Any last comments from you, Doc, before we log off?
No, thank you very much for this. This is the 3rd year that we're doing this. And I think that thank you very much for organizing this onboarding. But we want to say that we're also going to start doing just an orientation on maternal guidelines, 1-day refresher, you know, in the hospitals, just pull together a cluster of people. So we're going to have this on the 1st and the 3rd for Amathole, but I want to encourage the doctors in their region just to have a quick refreshers, you know, for everyone to be on par with the guidelines in managing the patients. But thank you very much for organizing this. It's very useful.
Thank you, Doc. And just give me a reminder for what is the webinar that's happening. Is it a webinar happening tomorrow? What time and what is the topic?
No, what is happening right in Central Region? So Fresh CMH Complex really addressing these issues of abortion. Someone will follow through from where I left off in terms of the topic of CTOP, and we'll talk about second trimester, we'll talk about the care. So Dr. Komodo will be presenting. There is a link that I have shared. So that one is from 7:30 to 8:15. So I think that it will help for people to attend that, you know, so we follow through on the issue of CTOPs. Okay,
if you email that to me as well, is that very specific in terms of planning for the Eastern Cape? So is it quite Eastern Cape specific, or is it nationally useful?
No, this one is just for Eastern Cape Central Region. We're discussing, we're presenting all the issues around TOP again.
Okay, that's very useful. And maybe just talk about the K training.
Okay, the K2 training, please, doctors, a lot of you have registered. We've registered people for K2. It's actually online. It's got 6 modules on CTG training. Really, intrapartum care is what is causing doctors to be staying at home without salaries today. If we don't address the training on CTGs, I did that talk, but people can go on to their K2 training. If you don't have your access, you've forgotten your password, you've forgotten your username, please ask any person, any DCST, you can also send me a message and say that I'm registered, but I don't have access, and we'll tell you how to just get access. because, you know, how to get your login details and but I really request 300 people have completed the course out of 1,500. So we really still need to complete this by the end of, we're trying for end of March, though we still have an allowance in April. So we really plead with the doctors, you do have the data for WhatsApp and you can do this K2 training. The other 6 modules of K2, it's also online. It's actually for the maternity crisis, emergencies, uterine rupture, sepsis, acute collapse, similar to ESMO, but it has got an interactive course. So I think the course is very good. There's been good feedback from those people who have done it. And I want to encourage those who are registered not to disappoint us, to complete the course. And the new ones, I'm registering the new ones in the different facilities that are new. But we want to make sure that we complete. And we're asking you that as part of your induction in your hospitals, you can have one person discuss each of the topics, you know, the maternity crisis or the obstetric topics, one topic a week. And then in that way, in the next 2 or 3 months, you'll actually finish the entire course and you sign attendance registers so that we can improve.
And Doc, that K2, is that just for the...
We paid R1 million to get this off, and we really need to show that it was value for money for the province.
And the K2, is that just for the Eastern Cape, or can people in other provinces also access it, or do they have to organize it through their own province?
No, there was a meeting we had in SASOG. We had representatives like from KZN in other provinces. So I think it may take time because of the financial issues to procure it. But I think from April, it will be available in other provinces as well. But as it stands now, it's the people from the Eastern Cape that are already logged in.
And there's a time limit to that. So the Eastern Cape needs to get a move on. And then for those of you in the other provinces, keep an eye out for the K2 training. An amazing online training that should hopefully be more available nationally.
Please,
thank you very much. Thank you very much, everybody. Doc, have a lovely evening. Apology for the tech problems. I've been chatting to my offline. We'll try and upgrade Zoom so we can allow 500 at a time. This 100 is just causing too much trouble.
But I think the main suggestion, Dr. Miller, is that the person who logs on must just log on like using hotspot from their phone, so that if the electricity goes off, then the speaker mustn't log on using their Wi-Fi. They must log on using a device or hotspot, so that if the electricity goes off, then they don't get kicked out. Because we tested hours on, but as soon as the electricity went off and I had to swap, then the whole thing kicked me out.
That was the problem. I mean, the other thing we can do as well, which somebody suggested, is that I'll just close the waiting room for a bit, so that I can make sure in the waiting room I let you in before. So we were talking anyway about upgrading our Zoom license for the 2 months. So we'll make a plan before next week. Thank you very much, everybody, and have a lovely evening. We'll see you. Well, the next webinar will be next week, Monday, and I must double check the topic. If it's a child, no, I don't think it's child health yet. Before I make promises, there's some very exciting things on the program. I'll send the webinar program around in the next couple of days, but our next webinar will be next Monday evening. Thank you very much, everybody.
Thank you.
Thank you. Thank you.